Hi, my name is Dr. Chatterjee, and I am a reproductive psychiatrist in Chicago. I work at a private practice called Meridian Psychiatric Partners, and I am the medical director of our reproductive psychiatry division. Today, I will be talking about peripartum psychiatric presentations and medication options. The goal of this talk is to discuss potential psychiatric presentations in pregnancy and postpartum, as well as treatment options, including medications. This talk will not be able to cover every possible illness, but I will focus on the most common presentations. So, what is the peripartum period, and how can it affect your mental health? I first want to offer a distinction between the terms peripartum and prenatal, as both can often be found in the literature. Peripartum period is defined as preconception, pregnancy, and up to 12 months postpartum, whereas prenatal period is defined as preconception and pregnancy. The peripartum period is a known risk factor for the onset or exacerbation of psychiatric symptoms. The peripartum is a perfect storm of so many stressors that can include a massive hormone shift, a psychologic transition of becoming a parent, a lot of sleep deficit, and some limited time to actually engage in coping skills. And so it is not surprising that the peripartum can serve as a vulnerable time for developing mental health instability. So for the next several slides, I will review possible psychiatric symptoms and diagnoses that patients can experience in the peripartum. So the first presentation that we will go over is peripartum depression. So what is depression? Clinically, we define depression as experiencing 2 weeks or longer of feeling sad, anhedonic, so not getting joy out of things that we would typically find joy in, having low energy, poor concentration, having a disruption to appetite and sleep, at times feeling guilt, and in severe cases, experiencing suicidal thoughts. What feelings and behaviors do we observe with peripartum depression? We tend to see people present with a lot of low self-efficacy, so just not feeling capable, guilt about not being a good enough mother, and poor self-care. This slide serves to demonstrate how prevalent depression is in the peripartum. The prevalence of depression during pregnancy is estimated to be about 13%, and 7.5% of those cases represent a first-time depressive episode. The prevalence of depression in postpartum is estimated to be between 10 and 15%, but a lot of experts actually feel this is an underestimated value. Even up to 50% of postpartum depressive cases may go undetected. And this may be due to poor reporting or the normalization of more pathologic symptoms in the postpartum. So what are the risk factors for someone to go on to develop postpartum depression? The strongest predictor for developing postpartum depression is having a history of prenatal depression. In fact, we have found that if somebody has a personal history of postpartum depression, they are at an elevated risk of about 50 to 62% chance of having a postpartum depressive episode with a subsequent pregnancy. Another identified risk factor is having a history of prenatal anxiety. This can often be surprising to my patients, as this may be the first time they actually are experiencing an episode of depression, as they historically are just used to having anxiety. Other risk factors include having a history of non-perinatal depressive episodes, having postpartum blues, especially if severe, and I will review more details about this in the next slide, having stressful life events, poor social supports, poor marital relationship, low self-esteem, childcare stress, and difficult infant temperament. So what is the difference between the postpartum blues and postpartum depression? Postpartum blues can occur in the first 10 to 14 days after delivery and is marked by mood swings, tearfulness, anxiety, irritability, and feeling very overwhelmed. Postpartum blues can affect up to 80% of people in the postpartum and is typically related to the massive hormone shift of being pregnant and going into delivery. Postpartum depression is defined by the persistence of depressive symptoms beyond 2 weeks postpartum. Just because somebody experiences postpartum blues does not necessarily mean that they will go on to experience postpartum depression. But we have found that those who experience more severe symptoms of the blues tend to have a higher risk of developing postpartum depression. So the next symptom I would like to focus on is peripartum anxiety. So how do we define anxiety? Anxiety typically involves excessive worrying and ruminating that may impact sleep, focus, and irritability. Other accompanying symptoms can include jaw clenching, headaches, muscle tension, and stomach upset. So what should we know about peripartum anxiety? The most common complaint is having difficulty sleeping when the baby is sleeping. It can affect up to 20 to 35% of people, and it is highly comorbid or often presents with depression. One of the most common questions I am asked is what is the difference between anxiety and stress, just normal day-to-day stress, which is a valid point. And I really like this graphic to hopefully kind of illustrate where we consider intervening for treatment. I always remind folks, to some degree, anxiety is useful. It's adaptive. We need stress. We need to feel some amount of anxiety to accomplish hard things, to get through tests, to grow our careers, to grow our families, and to be parents. And so that is what we're trying to achieve in general, is that green dot that you see, where you're really having kind of optimal arousal or stress, but also achieving optimal performance and productivity. Where we really tend to get concerned is when you kind of enter into where that red dot is. And so that is when arousal or anxiety or stress has really gotten too much, and it is ultimately leading to pretty poor productivity performance and can be very impairing. This can be hard to identify, like when have we gotten to the point of becoming more pathologic anxiety. And so that is where it can be very helpful to work with a clinician to kind of help assess that. So the next presentation I want to focus on is peripartum obsessive compulsive disorder, or OCD. So what are obsessive thoughts? This is defined as recurrent, persistent, or unwanted thoughts, urges, or images. Sometimes these are also referred to as intrusive thoughts. So an example of an obsessive thought could be having an intense fear of contamination. Compulsive behaviors is defined as repetitive behaviors that an individual feels compelled to perform in response to an obsessive thought. So an example of this could be excessive hand washing, perhaps in response to that obsessive thought of contamination. As you can see here, OCD is more prevalent in the peripartum as compared to other life phases. The prevalence of OCD in the general population is about 1%, whereas the prevalence of OCD in pregnancy is 2%, and the prevalence of OCD in postpartum is 2.5%. So what are common symptoms in peripartum OCD? The most common obsessions we see in pregnancy tend to involve contamination or symmetry. Symmetry essentially is being very fixated on the position and arrangement of certain objects. The most common obsessions in the postpartum tend to involve aggressive content, so typically seeing accidental harm coming to infant. And the most common compulsion in the peripartum tend to involve cleaning or checking behaviors. So I've put this slide in because I often find that there can be some overlapping symptom presentation with these three presentations. So postpartum OCD versus postpartum anxiety versus postpartum psychosis. So postpartum OCD involves intrusive thoughts that are ego dystonic and cause distress. So ego dystonic means that the intrusive thought that they're experiencing is not in line with their beliefs or their values. An example of an intrusive thought for someone experiencing postpartum OCD could be seeing accidental harm coming to your child. So perhaps while you're cooking, you're holding a knife, you are then flooded with an intrusive thought of stabbing your child. Another example that I often hear is walking around with your child outside and then being flooded by intrusive thought of your child being run over by a car. Understandably, these are very scary thoughts, but typically moms will very much describe that it is not in line with their values. They are not wanting or wishing harm upon their infant, and if anything, is causing a lot of distress. Postpartum OCD is often comorbid with depression, and we have not found there to be any increased risk for infanticide, which is a valuable piece of information, as understandably a lot of people are scared by these thoughts. They don't want to report on it for fear of being taken away from their child or being hospitalized, but we're actually very capable of treating postpartum OCD in an outpatient setting. Postpartum anxiety. Now, this can involve ruminations that are egosyntonic and when severe can cause a significant amount of distress. So an example of this could be maybe trying to figure out how to get yourself and your infant out the door so that you can get to work and daycare. Somebody with a significant amount of postpartum anxiety is going to spend a lot of time preparing and troubleshooting how to do this. And, as I've said before, anxiety is helpful. It is useful and certainly helps us do things and plan. However, it can at times veer into a more pathologic presentation that can be impairing and can be really intrusive on our ability to be engaged, focused, present, our ability to sleep, a lot of areas of our life. The reason I bring this up is that often I'll have people come in describing like, I think I'm having a lot of intrusive thoughts, which to me clinically really is more in line with thinking about a postpartum OCD presentation. But postpartum anxiety, particularly severe presentations, can really be marked by high ruminations, which can feel very intrusive. But at the end of the day, they are egosyntonic, and that to some degree, it is productive to plan and to actually, think about how to plan for certain things like getting yourself out the door. But where we do need to intervene is when things are becoming too much. It's becoming too impairing. Postpartum anxiety can often be comorbid with depression. And again, there is no increased risk for infanticide. Postpartum psychosis can involve delusional thoughts that are irrationally aligned with one's beliefs and do not cause distress. So an example of a psychotic thought could be mom thinking that sacrificing their infant is a good idea and almost necessary at the request of a higher power. So this is a delusional thought. It's irrationally aligned with their belief, and it is not causing them distress. Other symptoms that we often see when someone is experiencing postpartum psychosis can include hallucinations, disorganized behavior, and cognitive dysfunction. So almost like a confusion or delirium. Postpartum psychosis, as distinguished from postpartum OCD, is you can see in both cases, there is content that is describing harm coming to infant. But in the case of postpartum OCD, the mom parent is not wanting to engage in that, and if anything is very distressed by this. Whereas in the case of postpartum psychosis, the person is unfortunately irrationally believing in this belief and is not distressed by this. And as such, there is an increased risk for infanticide and thus a need for an emergent psychiatric hospitalization. So the next area that I would like to focus on is the impact of the peripartum period on fathers and partners' mental health. A lot of these statistics have kind of more specifically focused on fathers specifically as the partner. And so we have found elevated rates of depression at about 8 to 10% of fathers during the peripartum stage as compared to rates of depression in the general population at a similar parenting age is about 5%. So there is an elevated risk there. We've also seen higher rates of anxiety for fathers in the peripartum stage at about 4 to 18%. There's also a lot of belief that these numbers are probably underestimated, probably due to underreporting, particularly for fathers' cases, likely concerns with stigma or perceived conflict with masculinity. Also, symptoms of depression tend to present differently in men. We tend to see more aggression, avoidance, and substance abuse. There's also a very limited opportunity to screen for fathers or partners through OB visits or pediatrician visits. And so I think a lot of that contributes to us not maybe having the full picture of how this time can actually affect partners. So what are risk factors for a partner's mental health to be less stable? Understandably, comorbidity with birthing parent depression is a big one. Other risk factors can include the partner having a history of depression. We've actually found that partners have hormonal changes through the peripartum period. Other risk factors can include relationship distress, stressful life events, and a lack of social support. Partner mental health can negatively impact the birthing parent and baby. We have found that when partners' mental health goes untreated, it can interfere with the birthing parent's recovery as well as impact the child's development. And as such, there continues to be a need to focus on research, screening, and treatment of partner mental health, because just treating the birthing parent may not be enough. So when is it time to pursue treatment? This is a very common question that I get asked by so many patients, and one that I actually really enjoy answering. I usually say it can be very useful to assess what the impact of your mood or anxiety symptoms are on sleep, appetite, movement, your ability to focus, and your communication, particularly looking at your relationships with your partner, with your children, with family, friends, colleagues. And depending on the severity of those symptoms, the use of medication may or may not be necessary. I often tell people, when we're thinking about mental health stability and treating symptoms, I do think that we can approach it from 3 vantage points. And I do think that these 3 things can be fairly complementary. So that is lifestyle changes, therapy, and medication. So from a lifestyle changes perspective, I have a mantra that I often say, sleep, eat, move. I think it's pretty easy to remember, and I think it is something that a lot of people can align with. I think a lot of folks will say, hey, if I can sleep enough, if I can eat well, eat nutritiously, and if I can move enough, I do think that that is going to have a positive impact on my mental health. And to be honest, probably with your full health, with your physical health as well. And this is true. But I often tell folks, because by the time someone's meeting me, their symptoms are probably fairly severe. They're probably not doing these things. And I'll say, yes, you're right. If you can sleep, eat, move, you're probably going to feel better. But the purpose of working with someone like me or working with a clinician, therapist, anybody, is our hope to build your capacity to actually do these things, to sustain these lifestyle changes of sleep, eat, move. Because sometimes the activation energy that is necessary to actually be able to sleep, eat, move may feel insurmountable depending on the severity of your symptoms. And so that is where I find things like therapy, or if that's not enough, things like medication can be helpful. All right, so if we do decide to consider medication, one of the first parts of that conversation I have, particularly in the context of considering medication in pregnancy or postpartum, is there are some risks, certainly with taking medications. We will review that soon. But there's also risks in considering not treating your symptoms. And so what are the risks of untreated depression and anxiety in pregnancy? The risk to birthing parent can include development of postpartum depression and anxiety, higher risk for substance abuse, poor nutrition, poor obstetrical care, and an increased risk for suicide. Risk to baby can include a higher risk for baby to be born preterm, to be born at a lower birth weight, intrauterine growth restriction, so smaller baby, and can lead to a disruption of the maternal-infant bond. So if we do elect to consider medication as part of our treatment, what type of medication is indicated for treatment? So as I mentioned at the beginning of this talk, I'm not going to be able to review every possible psychiatric presentation or psychiatric medication, but the one that I will go over in detail today are selective serotonin reuptake inhibitors, or SSRIs. SSRIs are considered the gold standard to treat depression, anxiety, and OCD in the general population and during the peripartum period. SSRIs are considered low risk during pregnancy and breastfeeding. If SSRIs are not effective for you, please be assured to know that there are many other medication options available. I'm just not able to go through all of them today. So, what are the risks of taking an SSRI while pregnant? There are 3 low risks that have been identified. One is there is an increased risk for infant to be born preterm, so essentially delivered prior to 37 weeks of gestation. Importantly, there is no increased risk for infant to be born premature, so prior to 34 weeks. So we have found a slight increased risk for infant to be born between 34 and 37 weeks. As I had mentioned before, we know with untreated depression and anxiety that carries an independent risk for infant to be born preterm. So I sometimes will say, not getting treatment may have this risk, and starting the SSRI or continuing the SSRI may have this risk. To be fair, I would say a majority of my patients deliver term babies, so this is not a significant risk, but it certainly is an elevated risk that we have seen. The second risk is what's called persistent pulmonary hypertension in the baby, or PPHN. So when babies are in utero. The way that they oxygenate their blood is a little bit different than when they are born. So when they're in the uterus, they actually send their deoxygenated blood to mom's heart. She oxygenates the blood through her lungs and then sends it back to baby. When baby is born, after the umbilical cord is cut, that is no longer an option. And so a shunt needs to happen so that baby can adequately oxygenate their own blood. And what PPHN is when this shunt does not properly open. PPHN can occur in the general population to any baby in about 25 in 10,000. And when moms are taking an SSRI, that risk goes up to 34 in 10,000. So the actual increased risk, because you were taking an SSRI, is about 9 in 10,000 increased risk as compared to the general population. I'm also very careful to explain that PPHN is not a birth defect. This is not a congenital heart defect. That has not been shown to have an increased risk if you're taking an SSRI while pregnant. Congenital heart defects, birth defects are defined as defects that develop in the first trimester. PPHN is something that may occur in the postpartum and is something that is fairly treatable. Finally, the final risk is neonatal adaptation syndrome, or NAS. So we've seen when moms take an SSRI while pregnant, about 30% of infants may have transient signs of irritability, jitteriness, difficulty eating or breathing that may last a few days. So I say a few things about this. One, 70% of infants have none of these signs, and of those 30%, a majority really present as an irritable, fussy baby, which I think would be pretty hard to distinguish from really any other baby. On occasion, if the pediatric team notices that the baby is breathing fairly quickly, they may take the baby to the NICU to provide some support and supplemental oxygen. But to be fair, this really does not occur commonly, and when it does, babies tend to do very well, and they tend to get discharged within about 24 to 48 hours. Importantly, we've actually looked at if we discontinued the SSRI, would that lower the risk of baby to develop neonatal adaptation syndrome? And we did not see that to be the case. We actually followed women who took an SSRI for all of pregnancy, and then followed women who took an SSRI for a majority of pregnancy, but then discontinued the SSRI either 2 to 4 weeks prior to delivery. And in both groups, 30% of infants still demonstrated this neonatal signs. The reason why this is really important is because we do not recommend discontinuing your SSRI towards the end of pregnancy, because you cannot reduce your risk for baby to develop this neonatal adaptation syndrome. And we also know that third trimester, particularly heading into postpartum, is a very high risk time. The other piece that I really like to highlight in this conversation is that there are a lot of non-risks with taking SSRIs. As I'd mentioned before, no increased risk for developing birth defects. We know that in the general population, there's a chance for a baby to have a birth defect by about 3 to 5%, just because reproduction is complicated and error-prone. But we have not seen any additional risk to that 3 to 5% because mom was taking an SSRI while pregnant. Other non-risks that we've identified: no increased risk for miscarriage, no increased risk for developmental issues. There was a study that did show a slight delay in psychomotor skills in infants until about 18 months, but that delay was within the normative range, so it wasn't really something that was typically observed by parents, and for whatever reason, that slight delay caught up by 18 months. Finally, there hasn't been shown to see any impact on growth effects, and SSRIs are very low risk in breastfeeding. We have not seen a trend of adverse events in babies when moms have been breastfeeding while taking an SSRI. So naturally, the next question that often comes up is, which SSRI should I choose? So this is a complicated question, but what I will say is Zoloft, or sertraline, which is the generic name, is the most studied SSRI in the peripartum period. It also happens to have a very low transfer rate into breast milk. It's about 0 to 2%, and it tends to have a lower risk for NAS, or that neonatal adaptation syndrome. And as such, Zoloft gets discussed a lot as a treatment option during the peripartum. I do want to emphasize that not everybody responds to Zoloft. And so there are many other SSRIs like Lexapro, Prozac, and Celexa that have also been very well studied and, in my opinion, are fairly similarly low risk. And so I always really emphasize to people that there are individual reasons for why we may prescribe a certain med, whether it's based on efficacy or lack thereof, or issues with tolerability. But certainly if you've never really been on treatment and this may be your first time to care, Zoloft may be one of the first medications that we would consider during the peripartum. I also just wanted to review our approach to dosing medications during pregnancy. Patients will often ask if they can get to the lowest possible dose. And in general, I'm a really big fan of lowest possible effective dose, but I often provide some context to how we dose during pregnancy. So we know through the course of pregnancy that often medications are broken down faster. The reason why is the surging hormones of estrogen and progesterone can essentially induce enzymes in your liver that then break down meds. And usually the net effect is that the level of medication in your body goes down. Clinically, the way that we track this is if I notice worsening symptoms through the course of a pregnancy, I often will comment that I wonder if this is related to a drop in your medication level and we should consider an increase in dose. People are always inquiring, is that going to confer more risk? The truth of the matter is that it is very difficult, and we have not yet been able to really identify a risk stratification between a patient taking a certain dose and if that has higher risk or not. It is very difficult to do that kind of experiment. There's a lot that goes into dosing. And so at this point, what I typically say is the information available, those low risks that have been identified, have come from a range of dosing for these various medications. We do know that for most of these meds that the level does drop through the course of pregnancy. And so if you are feeling more symptomatic, it is reasonable to consider increasing the dose. And I often will comment that we're not necessarily increasing exposure to the baby. We're more trying to recalibrate your blood level of the medication because ultimately we want you to feel well, right? Like I will often tell people, if we have decided to take this medication, we have decided that this is an important aspect of your mental health treatment and stability, you're going to be exposing your baby to some low risk. And if we've already made the decision to take treatment, take medication, and expose baby to some of these low risks, it makes no sense to then feel unwell through the course of the pregnancy. So if you're not feeling well, do consider increasing the dose so that hopefully you can feel well, and also prognostically, it probably will be better for you in the long run. Well, I hope that this talk was helpful and was able to potentially answer some questions that you may have about how we do treat during pregnancy and postpartum. These are a couple of resources that I really like. I find both of these to be very evidence-based and to be very patient-friendly. Well, I really appreciate you listening to my talk, and I hope that it was informative. If you are someone who is seeking more information about this and potentially seeking treatment, please consider reaching out. I am a psychiatrist in Chicago. I work at a practice called Psychiatric Partners, and I am the medical director of our reproductive team, which consists of about 20 providers, both therapists and physicians, who are expertly trained in working with patients in the reproductive space. So thank you so much, and I hope you have a great day.